Welcome to This Explainer. Today we're unpacking a truly fascinating, multi-layered clinical scenario, the case of Bill. He's a 6-year-old rural indigenous child, and his situation is an absolute classic CCE exam station. To help lower your exam anxiety today, we've wrapped up this comprehensive, deep learning for the CCE exam in a cute, professional illustration style. So take a deep breath. We're going to break down exactly what the examiner's looking for, how to avoid their sneaky traps, and ultimately, how to score top marks through deep, empathetic understanding. Let's get into it.
Here's our agenda for today. First up, examiner traps and hidden tests. Second, managing scabies and glue ear. Third, the social context trap. Fourth, the rheumatic fever twist. And finally, mnemonics for exam success. Okay, let's dive into this. If you only remember one single thing from this entire explainer, make it this exact progression. Hand to ear to heart. You see, this case is not just about basic dermatology and ENT. The examiner's core philosophy here is to see if you can seamlessly connect clinical care to child development, family context, and population health. You're treating the whole child, their household, and their future all at once. Section 1, Examiner Traps and Hidden Tests.
Now, what's really interesting about this is how it maps the surface illusion to the hidden reality. The examiner throws an itchy rash at you, right? But they are actually testing if you can recognize infected scabies and not just carelessly dismiss it as eczema. They mention a hearing concern, but they really want to see if you can interpret otitis media with effusion to protect the child's speech and school development. When they present a remote child, they're evaluating your ability to manage health inequity without ever blaming the family. It is all about looking past the obvious surface stuff to demonstrate your public health and developmental competencies.
To gather the right information, we use a specific questioning framework for the rash. You've got to ask about the onset and distribution, sure, but crucially, you must ask if the itch is worse at night and if household or hostile contacts are also scratching. Ask about previous treatments, too. Have they used traditional remedies, steroid creams? And you definitely want to look for signs of secondary infection, like pus or rapidly spreading redness. Now listen up, because here is the ultimate trap. Never ever call this simple eczema and just hand out a steroid prescription. Doing that misses the scabies entirely, leaves the contacts untreated, and can literally worsen the bacterial infection. The rest of our questioning framework covers the ear, the home, and the child. For the ear, you need to connect hearing difficulty to speech delay and school performance, because honestly, sometimes a kid's hearing loss is completely mislabeled as a behavioral problem. For the home, you have to respectfully uncover those social determinants. Are they living in crowded housing? Do they have reliable access to clean water? Are there transportation barriers, or maybe passive smoke exposure? Finally, check on the overall well-being of the child, including sleep disturbance from that severe itch. All right, Section 2, Managing Scabies and Glue Ear. So based on that severe nocturnal itch, the fact that family members are itching too, and those oozing pustular lesions on his hands, our primary diagnosis here is impeginized scabies. Basically, that means scabies with a secondary bacterial infection. You've absolutely got to treat the scabies with 5% permethrin, but you cannot forget to treat that secondary staph or strep infection with an oral antibiotic like cloxacillin or cephalexin. The crucial point here is how you actually communicate this to the parent. Here is an exact high-scoring script you can use. 1. From the history and the appearance, this looks like scabies with a skin infection. It spreads easily through close contact, so this is not about being dirty. To cure it, we need to treat Bill and the whole household at the same time, otherwise it will keep coming back. This script is just perfect. It explains the permethrin plan clearly, enforces the household treatment, and completely removes any stigma or judgment from the conversation. Now for our second clinical issue. Based on Bill's audiogram showing an airborne gap and otoscopy showing dull amber tympanic membranes, we're dealing with otitis media with effusion, more commonly known as glue ear. This is basically fluid trapped behind the eardrum causing bilateral mild conductive hearing loss. And heads up, there's a massive exam trap right here. Prescribing medication. Routine antibiotics, antihistamines, and steroids are just not recommended for OME. When you're explaining glue ear to the parent, try using this high-scoring script. This can make him hear poorly, especially in class, so he may look inattentive or disruptive. I would like to support him at school, reduce smoke exposure, and arrange a follow-up hearing assessment. Notice how beautifully that phrase connects the purely medical diagnosis, fluid in the ear, to the child's educational well-being, all while gently addressing the risk factor of passive smoke. Section 3, the social context track. This brilliantly illustrates the difference between an average candidate and a top tier one. A high-scoring candidate actively talks about health inequity. They point out that delayed access and transport costs are definitely going to affect follow-up. They recognize that crowded housing directly increases scabies transmission, making isolated treatment completely useless. And they understand that a true public health approach requires involving the school, the district health office, and community leaders. You simply must use a practical, culturally respectful, family-centered approach rather than just lazy labeling a mother as non-compliant.
Section 4. The rheumatic fever twist.
Boom. Just when you think you've passed the station, the examiner throws a massive curveball. They tell you it's now 1 month later. Bill returns to the clinic with abnormal, jerky, purposeless movements in his face and hands. Well, what happened? Look at this timeline. On day 1, he had infected scabies and maybe a mild sore throat, a group A strep infection. 1 month later, his immune system has reacted to that strep, resulting in Sydenham chorea. This timeline right here is the classic bridge to acute rheumatic fever. And your immediate action? Same-day pediatric admission. No exceptions. You have got to quickly spot those major criteria for rheumatic fever using the Jones framework. We're looking for migratory polyarthritis, carditis, so be sure to listen for murmurs or tachycardia, Sydenham chorea, erythema marginatum, and subcutaneous nodules. The exact second you spot chorea, it mandates an urgent referral because acute rheumatic fever can cause permanent, devastating damage to the heart valves. They are going to need an echo, an ECG, and blood tests to find evidence of that recent strep infection. So how do you communicate this sudden, scary escalation to the parent? Use this script. The new jerky movements after a sore throat are concerning for rheumatic fever. This condition can affect the heart valves. I don't want to miss it, so I will arrange urgent hospital assessment today. This strikes the perfect balance. It communicates the severe urgency of the situation to ensure they comply, while keeping enough empathy in your voice so you don't cause sheer panic.
Section 5. Mnemonics for exam success.
Let's lock these dense concepts into your brain using some powerful memory tools. First, for the skin, just remember the word scabies itself. S, scratch at night. C, contacts are itchy. A, apply permethrin correctly. B, bedding and clothes need a hot wash or to be sealed up in a bag. I, impetigo present. Give oral antibiotics. E, everyone is treated together. And S, notify the school or health district if there's an outbreak. If you just run through this acronym, you will literally never miss a single public health or treatment step. Next, arm yourself with glue and dance. First for glue, ear. G is for glue or fluid behind the tympanic membrane. L is language and learning are affected. U means usually observe up to 3 months. And E, refer to ENT if it's persistent. Now for that rheumatic fever twist, remember to dance. D, it's delayed after strep. A, look for arthritis or carditis. N for nodules, C is for chorea, and E, get an echo, ECG, and evidence of strep. With these 3 mnemonics, you are totally armed for the entire clinical progression. We'll leave you with this final, provocative thought. In a complex case like Bill's, if we only prescribe a cream for the rash and completely ignore the crowded home, driving the infection, the fluid in the ears, impacting his education, and the transport barriers keeping him from follow-up care, did we truly treat the patient at all? Passing the CCE isn't just about reciting medical facts, it's about providing comprehensive, deeply empathetic, and holistic care. Thank you so much for joining this explainer, and good luck locking in that deep learning.